Hi, my name is Steven, and my project is titled Timing of Corticosteroids Impacts Mortality in Hospitalized COVID-19 Patients. As the global pandemic due to COVID-19 has progressed, there have been numerous inquiries into a variety of treatments aimed at decreasing the lethality of this horrible virus. Aside from social distancing and masking, there are currently no effective cures for SARS-CoV-2. Steroids have garnered a high level of interest since the beginning of the pandemic. Prior research on the original SARS virus suggested that early steroids may actually prolong viral clearance. Therefore, despite some early suggestions that steroids may reduce mortality amongst COVID-19 patients, RCTs investigating this topic were desperately needed. During the authoring of our manuscript, the Recovery Collective published their data on dexamethasone as the first treatment to show an actual mortality benefit amongst inpatient COVID-19 patients. Their paper demonstrated a survival benefit which correlated with increasing oxygen requirements. They also found that the benefit from steroids was not seen until 7 days since symptom onset amongst their population, regardless of oxygen requirements. However, this was minimally commented on in their manuscript and only included as a supplementary table. Our objective was to investigate the timing of corticosteroids and how this impacted survival amongst inpatients with COVID-19. In this retrospective observational study, we evaluated the medical records of 1,461 patients that were admitted with PCR-confirmed COVID-19. After EMR data was collected for all the patients within our cohort, we analyzed this to identify patients that had received corticosteroids during their hospitalization. First, in order to demonstrate that a mortality difference actually existed from steroids within our group, we evaluated a subset of 770 patients that were propensity matched. And in this way, we created a pseudo-experimental situation to evaluate mortality benefit in a retrospective manner. After confirming that a mortality benefit indeed existed, we aimed to examine the effects on timing among the entire cohort of patients whom had received steroids during their hospitalization. Additionally, we examined how the timing and mortality related to patients' oxygen requirements. So our propensity match group ended up being made up of 770 patients, and this group demonstrated strong matching quality with substantially less than 10% statistical difference amongst all of these variables. So this group was made up of 385 patients in each treatment arm. Among our matched cohort, we found a statistically significant mortality decrease related to steroid treatment with a hazard ratio of 0.67. Given the high quality of matching within the cohort, this finding demonstrates that corticosteroids likely provided an independent benefit on survival. While we found an overall mortality benefit from steroids within our matched population, further evaluation of time to initial corticosteroid dose after admission demonstrated that statistically significant difference in mortality only existed amongst the group of patients who had received steroids greater than 72 hours after admission. Looking at the time since symptom onset, our data agreed with the findings of the Recovery Collaborative. We only found a statistically significant benefit to mortality in a group of patients who had received their initial dose of steroids greater than 7 days since symptom onset. In the data published by the Recovery Collaborative, they separated groups into mechanically ventilated, requiring oxygen, and not requiring oxygen. While we confirmed their finding that patients requiring mechanical ventilation clearly benefited from corticosteroids, our conclusions were less aligned when it came to other forms of respiratory support. Unlike the Recovery Collaborative, we did not see a benefit among all patients requiring supplemental oxygen. Within our cohort, patients requiring high-flow nasal cannula saw a marginal survival benefit that reached statistical significance with a hazard ratio of 0.46 and a confidence interval that crossed the null value. The group of patients receiving oxygen via nasal cannula or non-rebreather showed no statistical significance with a hazard ratio of 0.84 and a much wider confidence interval. First, the current practice pattern seems to be that steroids are initiated if the patient is hypoxic, requiring any level of oxygen support. While the recovery data demonstrates mortality benefit amongst patients requiring supplemental oxygen, there is no granularity regarding the amount or O2 delivery device within their study. In our study, we found that patients requiring high-flow nasal cannula did portray a marginal mortality benefit that was statistically significant, while the non-rebreather nasal cannula group did not. Additionally, the non-rebreather nasal cannula group, we found a hazard ratio of 0.84 with a confidence interval of 0.35 to 2 and a non-significant p-value. While favoring benefit with such a wide confidence interval and no statistically significant p-value, it's possible that with a larger sample size, we could see harm from corticosteroids within this group. Overall, our data and the existing literature show that timing is a key element in the decision to start corticosteroids. Despite the fact that the recovery trial found no benefit for steroids among patients with less than 7 days since symptom onset, the major headline has become that steroids should be given to everyone requiring oxygen. We confirmed that despite needing supplemental oxygen, patients with less than 7 days since symptom onset showed no mortality benefit from steroids. We feel that this point must not be overlooked. Since now there are 2 studies that find 7 days as a key tipping point for benefit, given the recovery trial showed possible harm with O2 in this group, and that our data suggests that patients only requiring nasal cannula or non-rebreather may also face potential harm, it is very important to consider this time frame when initiating steroids for hypoxia alone. Additionally, we identified that greater than 72 hours since hospitalization was another key timing variable that should be considered when initiating corticosteroids. Overall, we feel that mechanical ventilation alone, regardless of time since admission or symptom onset, should be a trigger for initiation of corticosteroids. When it comes to patients requiring high-flow nasal cannula, given the marginal benefit to mortality, we think that if time since symptom onset is less than 7 days, you should consider withholding steroids until greater than 7 days since symptom onset or greater than 72 hours since hospitalization. It's reasonable to consider other factors such as inflammatory lab values and patient comorbidities, as well as the overall risk of steroids on a case-by-case basis within the high-flow nasal cannula group. Amongst patients requiring nasal cannula or non-rebreather, it seems clear from our data as well as that of the Recovery Collaborative that steroids should be withheld if less than 7 days since symptom onset. Unfortunately, given the headline from the recovery study, this point was somewhat glossed over, but we feel that our study reinforces this key finding. Additionally, it is reasonable to initiate steroids in this group at 72 hours since hospitalization, even if less than 7 days since symptom onset, based on our findings. Thank you very much.